let's try this again, everybody. We're going to start from the beginning. We're just going to do a double take and start over. It's Karen Anderson here with Aortic Hope, and we are here for tonight's live Q&A with Dr. Kristin Watson of the University of Maryland School of Pharmacy. And so normally what we'll do is we'll just talk, and then we'll have somebody we'll have people ask questions, but tonight's going to be a little different. We're going to try something technological. I'm going to have Kristin go ahead and introduce herself, and then we're going to actually share with you the slides that you saw us post earlier today. And we're going to walk you through some of the really important information about the medications that probably everybody that's going to watch this over the next few days and weeks, all of the drugs that you're taking. So they have side effects. They don't work after a half hour like a Tylenol. Some of you don't like taking any kind of medication, so it's pretty important that you have a chance to learn what these drugs are doing for you to aid in your vascular health, to aid in your condition, whether you are post-diagnosis of an aneurysm or you've just survived a dissection. So we're going to get into all of the nuts and bolts of that, and I'm going to turn it over to Kristin. Yeah. Thanks for sticking with us through technical difficulties.
Yeah, thank you. We're rolling with it and trying to figure it out as we go along today. So my name is Kristin Watson. I'm a faculty member at the University of Maryland School of Pharmacy. I practice in the outpatient setting in patients with cardiac conditions, and I'm so excited to be here with you today. I think it's really important for everyone to have a good understanding of their medications and why we take the things we need to take. It can be really cumbersome when we have a lot of medicines. I also know how challenging it can be when you get those big leaflets from the pharmacy department that has 900 side effects listed there, which can make folks understandably reluctant to take medications. So my hope today is to go through these medications with you, help articulate the importance of why you're taking them, and as well to go over what side effects are really most likely to happen and what we can do to help prevent them from happening. And then we have a few other things that I want to go over about general concepts taking your medications.
So the slides that you saw us post earlier today are going to go up on our website as well as in the notes section on Facebook. So, and through this live event, hold your questions for right now unless you have to leave, and then go ahead, of course, then post your questions. We will try to get to as many as we can. And if we end and you have questions over the next couple of days, we will get them to Kristin and she'll answer them for you, which would be great. But of course, whatever your doctor's telling you to take, it's not obvious you stay taking it. But maybe we can give you some questions and thoughts to take back to your doctor and have that, that dialogue with them.
Absolutely.
After tonight.
Absolutely.
So I guess we're going to try to
we're going to share our screen and our PowerPoint.
I'm learning something new. It's exciting.
How do we get to it?
I think it was up here.
Okay, get us back.
Yeah, it was right up here. And okay. Remember, it was right here.
Yeah. If we can't, we'll just roll with it.
Nope. Okay. I'm not sure where it went, but
I'll just talk and go over the meds.
Yep. I'm going to pull the slides up here so we can just at least look at them. So if you get a chance, go on our page, or if you can just listen to what we're doing right now, and we will take you through these slides one at a time here. Let me pull them up real quick.
Welcome, Bo. Congrats. It's been since 2012 that you had your dissection. That's wonderful. So thanks for joining us. I'm going to go through the most commonly prescribed medications for blood pressure. I'm also going to go through with you some things that you can do to help with adherence for medications and other things that are really helpful for patients with aortic disease. So I know I've heard that some patients can be very reluctant to take medications, again, especially when you have so many, and making sure we understand why we take what we take. So we know that one of the biggest reasons for aortic dissection, any heart event, even stroke, one of the biggest contributors is high blood pressure. So we know that by lowering blood pressure in your patient population is really critical to help preventing worsening if you have not yet had a repair or anything done, and to help prevent events from happening again in the future. So we're going to go first through our most commonly used medications, and then some of the others that are used, especially as we have people who we have trouble trying to control their blood pressure. So the first group we're going to talk about is the angiotensin converting enzyme inhibitors, also known as the ACE inhibitors. I love these medications. They're very effective for people who need blood pressure control, and they've really been shown to be beneficial in even the general population of reducing that risk of heart attack, stroke, and heart failure. So While it's important for you for your terms of your aortic disease, for overall general health too, it's really important to help reduce that blood pressure. So these agents, I call them, you can refer to them as the PRILs. The generic name all ends in PRILS. The brand names and the generic names are listed on the screen. There's not one that's better than another. The most common one we typically see used is lisinopril or enalapril in practice. And most of these are all generic, and you can get them generic through your pharmacies. Again, it all depends upon your insurance company typically, but they are very well tolerated medications. The biggest side effects is they can cause a dry cough. And I always say when the dry cough happens, the person who complains is not the patient, it's their partner who's saying they're keeping me up all night with that cough. So
now, when somebody gets the cough, I don't mean to jump in, but if I don't think my question, then you guys know we'll forget the questions. So when someone does get the dry cough, because it can happen right away or in a period of time, is that considered now you actually have a side effect and you should let your doctor know because you might have to change medication, or is it just something that you try to live with?
Yeah, excellent question. If that cough is at all bothersome to you, and like I said, it's usually your partner who's going to be bothered by that cough. If it's bothersome, you can go ahead and be switched to another medication. And you're going to go to a different class. So if you have a cough with lisinopril, if I give you enalapril, you're going to get that dry cough again. Okay. So ACE inhibitors have a cousin, which we're going to talk to in a moment, about in a moment. You can be switched to their cousin, and that does not bring on the side effect of cough. And it's important it's a dry cough, right? So if we're in cough and cold season and we're bringing up, now we're in flu season, you're bringing up mucus, that is not going to be your ACE inhibitor. That's hopefully just the cold and not the flu coming to get you.
Now, when you take an ACE inhibitor, how long does that usually take before it goes into effect?
Yeah, so for most of our blood pressure medications, you can start to see some effect within 1 or 2 days, but it's really going to be a week or so till you see that maximal effect on therapy. The one thing that's really important with all blood pressure medicines, it's that starting dose, mid-dose range is where you're going to see the biggest impact on blood pressure. Once you kind of go up to that top dose, you don't see the same impact that you got when you first started therapy. So don't be discouraged if they say, all right, we're going to up this again, and your blood pressure didn't lower as much from when you first started therapy, if that makes sense.
So if you take it, if you're supposed to take it morning, midday, evening, or what have you, and you take it, does it work within 2 hours, 4 hours? I know they're all a little different.
So all the meds are a little different. This one's going to at least take you a couple days to kick in to start to see your effects of therapy.
All right.
Big side effects the other notable side effect is angioedema. So this is lip, tongue, throat swelling, which can be life-threatening. That can happen to a patient at any time on the course of therapy. It is very rare, less than 0.1%. The risk goes up in our patients who are Black, but that would not make us not use this therapy if it was indicated. That is a medical emergency. If that happens to you on any medicine, get yourself to the emergency room so that you can best be treated. And then all the medicines you're going to see I have listed are dizziness or lightheadedness today. So anytime you start dose increase, I need you not jumping out of bed and running to the shower, getting your coffee. Sitting up, taking your time to get out of the chair and get going, just so we stay safe.
So the main benefit of any of the PRILs, any of the ACE inhibitors is to reduce your blood pressure. That's why you're being prescribed those.
And then if you have if you have kidney disease, other things, it has a lot of added extra benefits there too, and it will, just from high blood pressure in general, it's going to keep you alive and prevent that stroke or heart attack coming in the future.
Okay. Moving on to our next one.
Yeah, so these are the cousins of the ACE inhibitors. We call them ARBs for short, the angiotensin 2 receptor blockers. They work very similar to the ACE inhibitors. So the most common ones we see in practice are candesartan, losartan, and valsartan. I just saw somebody on irbesartan today, which we rarely see. Again, it's what's most useful in the practice, or most done in your practice. There's not one better than another in this class of medications.
Diovan.
Yeah.
I'm reading it. When I look away, it's not that I'm reading the screen over here with the slide. So talking about these drugs before we get into what they do, there's been so many recalls. And we got so tired, we just finally told everybody, go to the FDA and just go check it out. But what's going on with these drugs, and what do we do when we see these recalls?
Yeah. So it seems like the recalls die down and then boom, here we go again. So pharmacies have really been proactive because it's only certain lots. So every bottle of a prescription that comes has a lot number. So that can, for the distributor, et cetera, they can trace back which ones are the problem. So recalls, we're seeing recalls on new drugs now too, different drugs too. So the pharmacy can identify if they had that lot or not. So it may be one version of valsartan, known as Diovan, is potentially. We're not even really sure what that harm is, but we need to be safe with our patients and do the best thing and switch them. Your pharmacy is really going to be the liaison to help make changes and to get that communicated to you. We have seen a lot of people just switching therapy because they're saying, if they've never been on an ACE inhibitor, just go to an ACE inhibitor because they have the same beneficial effects, just because that headache of constantly having to go through this recall business. So complete frustration. What I do not want you to do, if you hear there is a recall, to stop this medicine on your own. I want you to talk to your pharmacy and talk to your provider, your prescriber, before doing anything, because what we don't want happening is your blood pressure going up. It's probably a long-term effect, the harm that this could potentially have. So taking 1 or 2 extra doses, I would feel, until you have it sorted out, I feel confident that that's not going to cause a problem for you. But it is a serious thing, and hopefully we're going to see a much better job in controlling that.
Now, I have talked with people in the community when they've been on losartan that they're just so lethargic, so tired. And I guess what wasn't explained to them is how long before their body adapts. And they also weren't explained, from what I understand, there's a benefit of the elasticity in the aorta. If you heard this, there's a benefit to losartan, which is why I think most patients are prescribed this.
Yeah. And so when they look at these different things, I haven't delved into that data too much, but sometimes they look at these, what we call surrogate markers. So they look at things like elasticity, or they look at how much blockage in a valve, and they specifically study one drug versus another. And I think if losartan really, if they have the most comfort with that and the most practice, that's usually what it comes down to. They're going to use one and stick with that in their practice. And there's really nothing that makes me think one is better probably than another. Who's to know? That might change in the future. But if you have a small subset of patients with serious condition and you have some small data that says this might be better, go for it. I always say give medication, unless you are down and out and cannot physically do things, give things a couple days to see if you can recover. There's different starting doses of everything. So if they start you on the high dose, they could potentially lower your dose down. I don't want you stopping therapy without talking to your prescriber, except that this lip, tongue, throat, something serious, and you're going straight to the emergency room and not self-managing that.
But with this one, it doesn't say anything about having a dry, hacky cough. So it might be, it's just a cousin. It's not, a twin. But it is, again, this is very specific drug that's prescribed to lower your blood pressure. That's what that one does. Okay. Moving on to the most common, the beta blockers, which are given to us in mass quantities. When they wake up from a dissection, we're like comatose from them. We don't understand them. So we really need to want to focus on this one a lot because they're usually in combination, but this is the other most important drug.
So when I used to practice in the inpatient setting, anybody walked in with any concern of dissection, lower the heart rate, and get that blood pressure under control. If that heart rate is too high, that is putting too much strength on the aorta and is going to risk things getting worse very quickly. So beta blockers are the best friend in this patient population, and you give it until you get your heart rate low. Blood pressure control, I cannot emphasize the importance of blood pressure control and heart rate control in those with aortic disease. We go faster and lower in this population in getting down to our low levels than we do in any other patient population, because we know how important that is for you, for your best outcomes. So these ends with the LOL. I just realized that it ended with their LOLs. Carvedilol, labetalol, metoprolol. There's different forms out there. Most of these are generic at this point. So you're going to be on one of those. It's really important that if a medicine tells you, I think about patients that I see, they'll say, oh, the carvedilol is twice a day. They're on the regular release. And they'll say, I can just take both at once. That's not what you want to do. If a medicine is twice a day, 3 times a day, and I'm going to bring this back up at the end too, you really want to be separating that equally in the amount of hours that you are awake. If you give it all at once, boom, heart rate goes down in the morning, and then if it's a twice daily med, and then it's back up later in the day, which is not good for you.
Now these take approximately I think my doctor said about 4 hours in a
Yeah.
day before they're really going to start working. Whereas the losartan, I think she said maybe it was 2 hours.
Yeah, you can see, and it depends upon what formulation that you were on. If you're good, so if you're on metoprolol succinate, which is a once a day, you're having pretty good coverage.
Okay.
These are going to, so that's why it's really important to equally space in your waking hours, your medications, based on what the, right? If it's every 12 hours, people are up for 12 hours. But like labetalol is 3 times a day. So figuring that regimen out for yourself is important. The one thing I will tell you, patients will always say when they start on beta blockers, they can feel really sluggish and tired in the beginning. Give it time.
Yeah.
Usually in 2 to 3 weeks, you're feeling much better. The drugs are so important that I don't want you to persevere if you're miserable, but again, you cannot self-stop this medication. It's so important. That
now let me ask you a question about that. So we're at a hospital, so we're here.
Yeah.
But so when I came out, I was taking labetalol, 300 3 times a day.
Yeah.
Could not, comatose, could not function. Switched to Bisalic, 5 milligrams twice a day. Completely different person. So just because they're in the same class, you might feel different. So talk to your doctor and just say this drug isn't working. Is there another one? Because they can put together different cocktails.
Yeah, and you can always try. Somebody reacts one way to one versus the other. You'll see sexual dysfunctions listed here. One thing I think that's really important to remember, we can treat sexual dysfunction. We cannot replace a beta blocker, right? So and people who have sexual dysfunction already have the people who have sexual dysfunction, you're at risk for that because you have something going on within the cardiovascular system, and you have that, right? So it could make it a little bit worse, especially for men, may bring it on. But I always say the benefit of the beta blocker far outweighs that, and we have ways that we can treat erectile dysfunction.
It's just for the women. There's
yes,
really
nothing we can do.
Right?
Yep.
Okay.
But and then other things, if anyone has diabetes, it's really important that this can mask, or like you won't see some of the signs of hypoglycemia. So you learn what your symptoms are, and you can check your finger sticks. And then I listed there for other conditions, and I can go in that. If anybody has specific questions, but you definitely do not want to stop this without talking to your provider, because this medicine is too important for your group.
Okay, moving on.
Yeah. And so now we have 2 different groups of calcium channel blockers. So these groups, the ones I'm going to talk about next, Thiazide and verapamil, you can see the amount of brand names that are listed here for you.
Yeah.
There's a lot of brand names. So this also lowers heart rate, and it can lower blood pressure too. So if someone can't tolerate a beta blocker for some point, they may substitute this or add it on as well to help get that heart rate lower. We really take advantage of it for heart rate lowering effect is when we'll use it versus for blood pressure because of the side effects that it does carry. There are drug interactions, but your pharmacist, your other providers are going to take care of that and making sure you're on that. The big thing with this drug is constipation with these 2 medicines. Drink your water, eat your high fiber like you're supposed to, and then you can always talk about different other options for that. People typically don't tend to say they feel as sluggish in the beginning with these drugs, but we don't use them as commonly. So you might feel, because your heart rate's lower, a little bit more sluggish, especially when you're trying to get up and walk around, and give it time and see how you go from there.
Yeah, I'd say I really haven't heard many people that are on this one, actually.
We always go beta blocker first.
Right.
And then, sorry, my mouth gets very dry. So then we have our non-dihydropyridine. So many of you may be receiving amlodipine or felodipine for blood pressure. Excellent blood pressure lowering medications.
And pretty quick acting.
They usually take around 3 days. These are a little bit different. It takes about 3 days to start to see your benefit.
Okay.
And blood pressure lowering with this. And then because we call it a half-life. So when it's in your body, it's in there for a long time. So you don't get peaks and valleys. And really you don't with any of these medications as long as you're taking them consistently. You get a nice blood constant control with it. The nifedipine, probably most of you don't see that because it can raise heart rate. And so we would really not, typically you won't see that in this population, but some may. And as long as you're tolerating that is okay. Side effects with this is it can cause swelling in the lower extremities, so around your ankles. And then that can be, the higher the dose, the more likely. Again, not everybody's going to have it. You always want to make sure to, again, talk to your doctor before changing therapy, and they'll figure out what the cause of the swelling is for you, because ankle swelling can mean a lot of different things. So we wouldn't want to just presume that it's the medicine causing it. But otherwise, it's a really well-tolerated med. I love it. I think it's a great blood pressure lowering med because people do really well on it, and it's very effective.
So these which are the ones that typically come with some diuretic built in?
So there are a lot of combination products out there. So we'll have 2, and we're looking to start getting some medications have 3 agents with them.
Okay.
So you can see amlodipine with another medications. Most common combinations are an ACE inhibitor with a diuretic.
Okay.
And I'll talk to you a little bit more about the diuretics in just a minute. There are, the other thing with the one thing, if anybody is on like the nifedipine, some formulations you see the capsule come out in your stool. Do not worry. And there are other meds that do that as well. Yeah. Clonidine is a kick butt blood pressure lowering medication, for lack of better words. There's different formulations of this. The tablet works very quickly. There's a patch that takes some time. You're on the patch. Yeah, and so the patch is really good, helping with consistent blood pressure control, because this medication, if you forget a dose or 2, we have what's called a rebound hypertension, and it can go higher than your baseline. So the patch is great, and then you're not 3 times a day.
Well, and the reason why was because I'm missing 3 feet of intestine. So everything by the ileum, which is what absorbs. Right. Now I know I'm definitely getting absorption one way or another. Yeah. Full, regular doses coming in. So.
And if I get somebody sustained on the clonidine on a good dose, I'm putting the patch on them. Yeah. It's just so much easier to do. Right. But it's important to not stop it suddenly if you're on the oral. And you can rotate the side if you have... rotate the site of your patch so that you don't get skin reactions from them. Side effects, it can cause a lowering of heart rate. Yeah. The older we get, the more likelihood you could have some like feeling a little bit more drowsy. You could feel sometimes a little confused. That's really when we're getting into our like 70-year-old plus population. Doesn't mean it's going to happen, and it doesn't mean it can't happen in a younger person as well. And you can get that dry mouth, which you may hear that I have right now. I'm not on clonidine, but you can get that dry mouth. If you have contact lenses and it's new, for you might feel your eyes are getting dried out with that. So it's a fantastic medication at lowering blood pressure.
The only thing you have to remember is if you are going to have an MRI, it's got to come off. And then they'll just put it on the side dish for you, and then you just put it back on, because it does have some metal base, some component to it. And then if you're out in the sun too, and you don't, there is an extra bandage that you can put on that helps protect it. I've never really needed it, and it's never fallen off in the pool or the shower, but I'm finding now if you don't put it on and you are out in the sun, it will make the skin underneath quite red.
Yep. So. And so clonidine is more of our second line medications. The medicines we talked about before are first line medications. They're very effective. Their side effect profile is much lower than some of the ones we're going to talk about. But if you need clonidine, and it works.
It does work. It works really well.
So the next one we're going to talk about, and this is often, we see this as early on therapy too for some patients, is a thiazide. So there's different agents. Hydrochlorothiazide is the one most commonly used, but we're seeing a shift in practice using more chlorthalidone or indapamide. They are older drugs. All of these are pretty old drugs, but we know that chlorthalidone and indapamide for other reasons are preferred. Now, hydrochlorothiazide is the one that's available in many types of combination products with other medications. It's also on your $4 list at your Walmart, those type of things. The really important thing to do with hydrochlorothiazide, if you're taking it, is slather that sunscreen on. Even now we're getting, depending where you are right now, we have snowflakes in our forecast here for Friday.
We do.
Yes.
That's great. Okay.
So even no matter the time of year, I think we all fall into this misconception like, hey, it's not sunny outside, it's not the summer, but we still need to be applying our sunscreen. Right. So like if you just have your face exposed, I still want your face covered with sunscreen. And gout, right? So if you don't have gout, the likelihood of this medication causing gout, but people who may have gout, some people, it could potentially worsen it, but we would make that decision. If you're on good medicines for gout and you need this, you're going to get it. That's such a patient-specific decision to make. But otherwise, if you're doing okay, the likelihood of you getting gout from it is very low. So don't worry about that.
Now, is that the type of drug, see, I was prescribed that for myself to take on an as-needed basis, because what I was finding for myself is if I took it more than 1 or 2 days in a row, my right kidney actually would start to burn and would start to hurt. And then they would tell me, well, if you're not urinating frequently, then just don't take it, because maybe there wasn't any extra fluid left to come. So I was taking it if I found that I was swelling or retaining a lot of fluid. So is that... typical, or is it really something you need to be on it every day?
That's
consistent?
a really good question. So our thiazide diuretics, this group here, they're really not water pills. We all keep saying that we need to reclassify this group of medications. There's furosemide, which some of you may take. That's a real water pill that you can take as needed.
Okay.
This, you get a water pill effect within the first couple days of therapy. We don't really know why this works for blood pressure control, but we don't care because we know it does. So the first few days of therapy, you're going to lose some water and extra sodium. Okay. But after that, you kind of just baseline out. So this is not something I would ever personally have someone take as needed. Again, everybody's different. If it was a fluid thing, it would be more so your medicine like furosemide or Lasix that you would use. Okay. Great question. I love these questions. These are my favorite medicines. Right. Everybody who knows me knows that I love the aldosterone antagonist. So these are really effective in when we say someone has treatment-resistant hypertension. So that means you're on 3 blood pressure lowering medications, including one from the class we just discussed, and you're not getting to goal. These drugs work. And they get blood pressure down. So you may see it added on. The big takeaways I want you to remember with this, if you would take this, this increases potassium. Salt substitutes that look like salt, and really if you're on some of the other medications we talked about, like the lisinopril or a losartan, those type of medications, those salt substitutes that look like potassium, I really don't like my patients taking because they are high in potassium, and then that can interfere with us being able to use the right doses of medication. Okay. So if you're going to season your food, because you all know you're supposed to eat low sodium, and we all know how hard that is, you want the herbs that look, it's the herbs. You don't want your things with salt in it, and you don't want the things that look like table salt as a replacement because it's high in potassium. Okay.
So that Mrs. Dash or whatever.
Mrs. Dash is perfectly fine. Okay. I love me some garlic and rosemary, so I'm always trying to get my patients on that. But yeah, if it looks like seasoning, you're okay. But if it looks like table salt, no. Okay. And then the side effects are here for you as well. Spironolactone can cause some breast tenderness or swelling. Its cousin does not.
Okay. All right.
And then,
yes, I've been prescribed. That's what it was, the Lasix. But I've seen the HCTZ and another drug as a combination.
Yeah. So HCTZ is really good is used for blood pressure lowering. Okay. These are our water pills. They are called loop diuretics, just based on where they work inside the kidney. So Lasix is the most common one that we see. Fun fact, it's called Lasix because it lasts for 6 hours. That's where they got their brand name. Yep.
Okay, got it now.
And then the other two, we use those more commonly in people who have heart failure. So some of you may or may not have seen those. Side effects, the big thing is dizzy or lightheadedness, right? Take off water. Yeah. One thing we do constantly see, I take care of a lot of people with heart failure, and we constantly see people telling them to restrict their fluid intake on this medication. People see this on the internet. That is not something we want you to be doing. You drink, right? Yes, don't be excessively drinking, but we don't want you limiting yourself to a specific number of glasses of water per day for this, because that can cause you to get in trouble. What's important is when to take these medications, right? So if you take Lasix twice a day, one when I'm married to an overnighter, so one in a good time. Take one when you're first waking up and out for your day. Take the next one in 6 to 8 hours. Because last 6 hours, I don't want you taking it within that 8-hour window of you going to bed, because then you're going to the bathroom all night, right? Yeah. So it's always really important to take in what works for you. I had a patient before who worked on the trade floor in the stock market. There was no way he could take it before medicine, right? So you got it before work. And the other ones last a little bit longer. But again, making sure giving yourself enough time before you have to go to sleep to take the medicine. And then hydralazine, just like clonidine, super effective blood pressure lowering medication. It is 3 times a day, so we really try not to use that unless we have to. Okay. Some people need it, and when you need it, you need it. Side effects, the biggest thing I'll hear is like stomach upset from patients for that.
I've never even heard of that. Okay.
Yeah. And then tobacco cessation, this is near and dear to my heart for everybody and their mother. One thing I wanted to say earlier, even though some of this may not apply for you, it may apply for someone in your life. Yeah. Smoking cessation, tobacco cessation is one of the most important things we can do for ourselves, no matter what our condition. Smoking cessation, tobacco cessation is the hardest thing to quit. I have patients who come off alcohol, they come off hard drugs, and getting them off of nicotine is a real challenge. There are different products that are available for you. Find your healthcare worker your healthcare provider who you know and who you trust, and get them to help you. Even if it's just, they should be starting a discussion at every visit, but getting that discussion going at least to start thinking about it. Don't be discouraged if you don't quit the first time. It is very hard for people to quit, and you want to find someone who's going to really work with you. I put on there 1-800-QUIT now. My patients love it, and the resources that they get from there to help them stop smoking.
I have 2 questions about all the drugs we just talked about. Sometimes with prescriptions, antibiotics especially, you're not supposed to take any grapefruit. Does that apply to any of these drugs? And second, alcohol.
Yeah. So the grapefruit could potentially interfere with the Thiazide and verapamil. But what we have found, you really have to consume significant, it's like liters of grapefruit juice. So I always say if you're having a grapefruit for breakfast or you're having a glass of grapefruit juice, that's okay. If you're on like, the new fad diet is now we're all into grapefruit juice, right? Yeah. Don't be doing that. You shouldn't be doing that anyway, because that's not going to be effective for your health. But yeah, by all means, if you love a grapefruit in the morning, have your grapefruit in the morning.
And then what about alcohol beverages?
Yeah, so alcoholic beverages, everybody really needs to maintain. There's certain conditions where you want no alcohol. I'm not saying to go out if you're not drinking now, to start drinking every day, but women really should be 1 drink per day. And remember, like, what 1 drink is really considered, and then 2 drink per day, right? So it's not getting the really tall beer at Chili's is
so
1.
What is it?
So like a 16 ounce,
one?
like a 16 ounce beer is a 6 ounce glass of wine is okay. So my patient's like, I have 1 drink, and then what is that 1 drink? And they tell me it's a pint of something, right? So really in that, making sure that you're having what the sizes. I think it's helpful for patients if you get something, if you're a beer drinker, making sure you're really paying attention to that ounces. Everybody wants to supersize everything.
And that's okay with all these medications.
It's okay, but it's really important to have that discussion with your provider, because certain things with the heart, for instance, heart failure people, we say no alcohol. So it's really important to have that discussion with your provider. I would imagine that if you're having alcohol already, you've had that discussion with them. But if you're like, hey, I was never a wine drinker or a beer drinker, now I'm thinking of picking it up, have that discussion, because everybody is so different that we can't give a blanket statement. But if you're going to do it, you really, women 1 drink and men 2 drink per day to really do that.
And here we are.
Cough and cold season is coming upon us. Yep, got flu coming. So here's the safest thing for everyone is stay hydrated. Tylenol is the best option for pain, headache, those type of things.
What's wrong with that, though?
So ibuprofen, Motrin, Aleve, all of those, they can potentially raise blood pressure. They can increase your risk of having a heart attack or stroke, especially as we age. They can cause problems with the kidney. So Tylenol is safe for every age group, right? And it's very effective in breaking fevers, helping with the pain that you may have. I am really an advocate of not using combination cough and cold products. Again, I'm a pharmacist, and I walk in that cough and cold aisle, and I'm like, oh my Lord. So I'm really about using your products all separately so that you understand, or talking to the pharmacist in the pharmacy to help you out, and letting them know what's going on.
So again, because I know when I got really sick, the first time I was told, go get some Quercetin.
Yeah.
But you're saying kind of keep them and be a little bit separate.
Yeah, and then the other things you find, some of these other products in these cough and cold preparations, some of the men on here may be middle-aged and they have problems with their prostate. And then there's things in some of the combination products which aren't good for your prostate. Cough and cold treatment, I say Tylenol, saline nasal spray, which costs you $1, and a good old humidifier, and drinking hot and cold fluids.
And just get it out.
Because even when you talk about cough suppressants, we don't want that cough suppressed. Now, if it's a problem at night and you can't sleep, well, we want you to be able to get it out. So drink that fluid, use your saline nasal spray, and Tylenol for pain. And then some TLC from somebody.
And get your flu shot.
So every patient group benefits from a flu shot. If I see you and you don't have your flu shot, I will come talk to you about that. There's a lot of misconceptions about vaccines there. Everyone in my family is vaccinated. My parents are, are really good about doing that too. It can save your life. We know people with heart disease, vascular problems, it can save your life. You may not prevent, it's like a seatbelt, right? You may not prevent you're not going to prevent being in a car accident, but you're going to prevent dying from the flu if you have it. So get your shot. It's not too late.
Okay.
And then medication adherence is critical to ensuring that we can have good blood pressure control, keep you guys in the same shape that you are in right now, preventing things from ever going downhill. Medication, same time each day. Find a schedule that works for you. So what's your daily routine? What time works best for you to take your medications? Do an alarm. I just had to take something 4 times a day. I thought it was the most awful experience. So I had 4 alarms going off on my phone so I could remember. Yeah, and I talked about this earlier. So if you have a twice daily medication, it's every 12 hours apart. If it's 3 times a day, like if you're on clonidine tablets or hydralazine, separate it 8 hours in your waking hours. I don't want you waking up from sleep to get that 3rd dose in. And then find what works for you. Talk to your friends, see what works with them, and talk to your partners or whoever you live with in your home, because they know I always tell my husband, I know him better than he knows himself, right? And like what works for you, and you're probably your same thing. Your husband probably can tell you this is going to work for you better. So find someone who you trust and to help figure that out. Whoops. Yeah.
So quick question about timing. 2 times a day.
Where are we at?
Where did we go here? Oh, there we go. So 2 times a day or 3 times a day. So one morning you wake up at 6 a.m., you're taking your medicine. The next day you sleep in, you wake up at 8. You're not going to die if you didn't take. You don't have to set your alarm.
Yes.
Get up and have that bite of pudding or whatever you're going to eat to take your thing. You can just take it when you wake up and you should be okay.
Yeah, we always say if you're in within that 2 to 3 hour window, and every medicine is a little bit different, but for these, if you're in that 2 to 3 hour window and sometimes a little bit more, take it. I do not want you setting your alarm. If you did not have your 8 hours of beauty sleep, I want your 8 hours of beauty sleep because that is important. There's a lot of talk. There was stuff that came out last week talking about the right time of day to take your blood pressure medications. And there's been a lot of chatter about nighttime might be the right time. Anybody who watches PJ Masks with little people, you might have started singing that song. So that nighttime might be best. We don't know that for sure yet. There's some evidence that suggests that nighttime dosing of blood pressure medicines may work. It's all about finding what's best for you and to see with that regimen. If taking it at nighttime works, it's not going to hurt you. Not everybody's probably going to benefit from this nighttime dosing. But it will not hurt you. It's really finding what works for you.
Now you talk on here to use an alarm or an app on your phone. What app?
I haven't found an app that I like myself.
Somebody create an app and become a millionaire.
And I think every app has what works, what doesn't work, and you just play with it, right? For me, it's an alarm clock. I have all my friends use electronic planners. No, I'm still rocking my pen and paper planner, right? So you just have to find what works for you. When I've tried to do even different apps for running, I went through them all. Guess what I have? A little notepad in my office and my house. And we have our own, because a lot of people in my house are on meds. We have our own alarm system and our own homegrown medication tracker. So it's really what works for you. If you're not, I use technology, but that stuff just is not part of my day.
Now I'm going to throw something out there to those of you that are actually watching this right now. I just decided I would do it. So we have a little teeny keychain pill case, which is perfect for that on the go, or if you have very distinct looking medications. The first 10 people that want to send us a message tonight and with your mailing address and your name, I'm going to send you a keychain, an Aortic pill case. Why not? We're talking about pills. Let's get it out. So first 10 people to send us your information, we will send you a pill case this week. So I thought I'd throw that in there. So this is great. This is such amazing information. I think we should probably start to take some questions. I'm going to let you do that on your computer because I don't know where your scroll button is.
So if anybody has any questions.
What is chronic thoracic aortic dissection? I don't know.
I don't know that answer either.
Okay, we'll look into that.
Yeah. I don't know if it's much different than aortic dissection. It might be talking about the different from where the dissection stems from or where it's going. I don't know that answer, so I'm not going to try that.
So Kevin stopped because of a cough. I'm going to guess it was one of the prills, probably, right? That's what you said. Bo takes lisinopril and takes, I guess you meant to say metoprolol, probably.
And amlodipine.
Right, that's probably what you meant.
Okay.
Right.
So Bo, I'm not sure if you have a specific question. Most of the medications you're on are once a day. This is Bo Chamberlain, but I think there are some people who do have to take them twice a day. And if that has been what has worked for you, that's okay. But most folks will just take those 3 medications once a day.
And so Michael wants to know if you have any insight as to why so many drugs are being recalled.
Yeah, and I think this is a real challenge and a real worry for so many of us with these recalls. So what seems to be the problem is that the manufacturing is occurring outside the United States. And so is it that we don't have good control, good regulations over there? I think what everybody would really love and hope for is that we brought that manufacturing back to the States so that we have the oversight here, that we could really provide that best oversight, because we can't be messing around with your medications. I unfortunately just saw some data the other day. I think it was the sub-Saharan desert, that the area that like only 10% of their medicines are deemed safe and really effective. Wow. So it's really unfortunate. So thankfully, the FDA is looking into this now, and hopefully we'll have a better process soon and figure out what we can do, because I can't imagine being the patient. We see our side of things on the recall, and we're not the patients going through.
And if you don't know where to find the lot number, it can be really confusing. So just if you're ever concerned, call your pharmacist. My guess would be that if you ended up having a lot number, they're probably going to call you before you even get to them. So
yeah, I know a lot of people are always very good about sending letters out and letting you know.
So Justin is talking about, is it bad that with the issues he's having, that since the doctors don't seem to want to look at the problems or meds, that you're finding another doctor? Nope.
Yeah, I
find another doctor.
I always say to you, you have to have the right fit. It's got to be a good personality fit. You have to trust them and that they're going for you. Second opinions are always great, because maybe something else will not be thought of. And I'm all about finding who works best for you.
And Justin also mentioned that beta blockers gave him migraines. Have you heard that before as a side
effect? That it gives you migraines. I have not heard that it's given migraines. We actually can use it to help prevent migraines from coming on.
Now, I've also heard that sometimes a higher dose beta blocker can help women with hot flashes too.
There's a lot of different things that have been out there with different hot flashes.
I think it's real.
Yeah. I think the only thing that's really, now granted, I don't keep up with women's health because I'm at the VA and I deal with mostly men, older men. But like the only thing that's really worked for hot flashes is like an antidepressant. But hey, if it works for you.
It did.
And
it worked.
Some beta blockers get better up into the brain, like others do, like propranolol, and may be a better help for that.
So Michelle wants to know, is there any danger in the aluminum that's in that clonidine patch?
Yeah, so that's a good question. Not that I have heard of. We do want to be careful if we get a fever on our patch, so we talk to let our provider know that if we're ill. Sometimes you will say, heaven forbid anybody's ever hospitalized. Sometimes they do take the patch off and they would put you on the tablets for the short term. Just if there's any problem, like blood pressure getting too low, just so they can control. Clonidine, you make dose adjustments and your blood pressure follows suit. So it's a really lovely drug like that, as opposed to our other medications.
And that's also important, because if you're on the patch, and I don't know, I mean, the timing stars have to align. I've had to go to the hospital on a clonidine patch change day and just did not grab one with me. And you got to make sure they know, because you will have rebound blood pressure issues.
Absolutely.
Okay. So it looks like, so if you take it at night, I'm assuming she means the
water. Yeah. So if you would take the furosemide at night, or the bumetanide or torsemide, they're all generic medications. That would cause you more frequency at night. The other medications will not increase your urine output, so they would not. You're not going to see frequent urination. And the other thing, so again, we have some men on here who may be middle age. Again, that prostate. So it can be really tricky. So if you're getting up to run at the middle of the night, what is doing it? Is it your prostate medicine? And we also have meds that are really good that can lower blood pressure and are good for enlarged prostates.
Okay, that's good to know.
Yeah.
So Kevin said, we mentioned that certain category of drugs that if you're on 3 or more, that there's something else that they can give you.
Yeah, so good question. So if you're on 3 or more drugs, and it also depends what 3 drugs you're on, if your blood pressure is not yet controlled, spironolactone is really effective. And there may be a reason that they need to use
slide was that
something, the aldosterone antagonist.
Okay.
Spironolactone or aplerenone. Spironolactone has been around for a very long time. Aplerine's newer, so it's more costly. But the aldosterone antagonists are really effective if your blood pressure is not controlled with 3 drugs. It doesn't matter which 3 drugs you're on first. Beta blockers are very good for lowering heart rate, but you'll usually try something else specifically for blood pressure, maybe before you add on an aldosterone.
So if you need that information again, Kevin, check out slide number 9. And I'm not too sure how, I guess it would really depend on how engaged of a cardiologist you have or surgeon that would think of something like this. So there's nothing wrong in taking this information back and saying, hey, I heard this. I don't know if I'm on the right 3. Can we consider this spironolactone? And then try to say it 3 times fast. Okay, so Michael mentions that he takes that drug right there. And gets muscle cramps.
Yeah, so Michael, I guess my question for you would be if it's in the lower extremities, if you're getting muscle cramps. I have not heard of it with carvedilol. When I hear muscle cramps, I usually think of, are we getting enough fluid intake? And if it's more so muscle cramp, or is it pain in your leg? Because if it's pain in your leg, that could potentially be, especially when you're walking with pain in your legs, given your age, other risk factors, that could be that there's some blockages down there. So I want you to get that explored first. You know, we've seen things about you can take different supplements and different things to help with leg cramps. Drink your water. But if you are having those muscle cramps and are staying hydrated, I would really talk to your doctor and talk about when they come on, what brings them on, so that we could make sure that they're really cramps. And if they are, and it seems like it started with the carvedilol, it's never, you can try something else in the class to see that happen.
Okay, big one here from Betsy. Takes Cardizem, am I pronouncing it right? To prevent coronary spasm. Asked the cardiologist about adding a beta blocker for ascending aneurysm. He said the other drug was just as good to take, and I didn't need a beta blocker.
So in certain patient populations, we know that you need to have a beta blocker on board before Cardizem. And that's people who just had a heart attack, people who have heart failure. Outside of that, if we're using the medicine solely to lower heart rate, we're okay with using the Cardizem as still Thiazide, but that is usually okay. And that's actually much better for coronary spasm. So I think that's perfectly fine. If your heart rate's low, I think it was Betsy. So and again, we don't want to add a beta blocker on just to add it on, because if the heart rate's already low and we add it, you're going to have a heart rate lowering and you're not going to feel well. And it could be, we don't want anything serious to happen to you.
All right, we are at that 46-minute mark. So if anybody else has any questions, now's the time to get that in for tonight's live event. And then, of course, anything that you add in after Kevin asking when I'm finally going to meet him face to face, since he doesn't live far from us, to grab lunch. So we'll pick up all the other questions, and then we can talk about some of those answers when we have a chance. So if anybody has anything else, now's the time to ask. Otherwise, this is so unbelievably informative. I love when I can have an event and I can walk away saying, I just learned something new myself.
And I learned from you all, and these are great questions. I always appreciate the questions from patients, because then it gives me good insight when I'm talking to a patient, again, questions that they may have, and sometimes they're afraid to ask. Oh, the last thing I want to say before we wrap up is whenever you have questions about your medications, I think it's really important to write that, if it's about your questions, your health, to write it down. Karen and I were sharing some health stories earlier, and I know stuff going on with a family member. We have a running list, either in our phone. I do use my phone for that sometimes, and then I forget where it is, or a running note in my notebook of questions that I have, so that when we have follow-up appointments, my sister just gave birth, and some stuff was, I had all my little notes written. So, because when you're in that moment, you forget to ask those questions. And I always say, if you you have a good provider when they're willing to listen to every question you have and to give you an answer. And if they tell you they don't know, that's okay. You'd rather them tell you they don't know.
I mean, it is important if you have any questions about why you're being put on a drug, and especially if you have to go to the hospital for an emergency, make sure that it's very well documented that you're on certain types of drugs, and ask questions. I can't tell you how many times I've been in the hospital and they're just starting to give me medications and they're not telling me what it is, and I want to know what it is and why. And don't be surprised if you take one type of drug and then in the hospital they give you metoprolol, because that's, I'm not pronouncing it right, but that's what they standard try to give. I mean, so if I'm taking Biostolic and all of a sudden I'm getting something else while I'm in the hospital, it's okay. They're not going to poison you. It's still coverage. You're going to be okay, but it's still important to ask the question. All right, let me see. Did we get? Oh, we have more comments. All right. You're welcome. You're welcome. You're welcome.
So there's metoprolol causes vomiting soon after taking it. I have not heard that. I would look to see, but again, everybody's different. I would look to see if something else is going on. they could try a class effect. It could potentially also be that the taste of the pill they don't like. That just didn't.
Yeah.
I just had to take prednisone for something.
That's disgusting.
And I was like, oh, this is gross. So I the next time I took it, I made sure. So it could just be the taste. And
Plavix is another one. I don't know who out there takes Plavix, but as soon as it literally touches the tongue and the bitter, it's so overwhelming that it's enough to make you gag. So you're right. That's a good point. It could be that it's not well coated, and maybe you just need a different type of pill or formulation.
Yep.
Can they do it differently like that?
Yeah, metoprolol is generic. So there's 2 different forms of metoprolol. They could always try a generic. Yeah. But we don't. There's only in people with a certain type of heart failure does it matter what beta blocker you get. So as long as you're on the right dose and the right frequency of administration, metoprolol, carvedilol, they're usually the ones we're most commonly using in practice. You can try another one, and they're, we substitute them if we need to. But I'm gonna hang my hat on that taste thing if I had to. But if they're having the problem, switch the medicine just to be safe, because we know in this group how important beta blockers are for you.
And now, this is a really good final question. I think it is, because it's my
all right.
question.
Let me see if I can be ready.
So many times, those of us that are Medicare and we have our Part D or whatever the case is, we are struggling with trying to get the right dosage. And so you're finding, like, for instance, I needed to be on 5 Bistolic. They would only give me a 10 milligram pill once a day. I needed 5 twice. You cannot cut a triangular shaped pill. You cannot cut pills that don't have scores. It doesn't matter how much you use a pill cutter.
Yep.
So give your thoughts on that. I mean, I say keep fighting with it, because you should not be cutting pills that don't have a score.
Yes, 100%. Is making sure if it is not feasible to do, if it's crumbling, if it's not scored, you should not be cutting it. And there are a lot of I think pretty much all of these can be cut. We cut a lot of them in our practice for financial reasons. And a lot of people do, and that's why they do that on different formularies. They want you to cut it. Make sure your pill this might sound silly, but make sure that oh my Lord, the pill splitter is in good shape, because they do get dull after, depending how frequently you're using. Right. But keep fighting those insurance companies and fighting for what's best for you. Keep it up. And I applaud all of you for the challenges that you encounter with the prescription healthcare, prescription and healthcare, because it is very challenging. But you're a better advocate than you are.
All right, we got a couple more questions. So, article today that said aspirin affects blood pressure.
So there's always something about aspirin in the story every day. No, I don't think that if you took loads and very, very high doses of aspirin, theoretically you could potentially see a change in blood pressure. We have really moved away from for most people, right? We're not using aspirin. Your group is going to be a little bit different. Many of you may be on that. You may be on
baby aspirin,
like that low dose aspirin. So I do not have it. If you're taking 81 milligrams of aspirin, 325 milligrams of aspirin, that it will not affect your blood pressure. You do want to make sure that aspirin is needed. I don't want anybody saying, I'm not taking aspirin, I need to start it today. We need to have a true indication for aspirin to take it. Otherwise, our risk of bleeding goes up.
Right. Okay.
And if you're on it, do not stop it without talking. Do not stop anything without talking to your provider.
Nothing we discussed tonight. Everything you stay on, but take this information back and have that discussion with your provider.
So Sally was on latenolol, but her heart rate was low. It depends what dose of atenolol you were on. So 25 milligrams is typically our starting dose, and 100 being the maximal dose we'll use during the day. So it depends what dose they started you on. If you had a low heart rate on the starting dose, you're going to have a low heart rate on the other therapy.
Yeah, so she's saying it was too low. So any of those other type of beta blockers
are going to give you the same effect. It really depends on what dose they use, because if they put you on a big dose up front, maybe they need to lower your dose. So there's always different things to taking it. But if you're on low dose, it's going to give you low dose with another.
Because I was on 900 a day of labetalol, and then, like I said, couldn't move, and then they switched me to 5 of Bistolic twice a day, and it was like the clouds parted, and all of a sudden I was functioning. And so I would say, like you're saying about dosing, to have that conversation with your doctor for sure.
To see what that is. Yep.
See, now the comments are rolling in. Okay, she was at 25
and then went to
12 and a half.
Yeah, if you went down to 12 and a half and your heart rate was too low, we're not going down any lower on that. And there are some people, especially Sally, if you're a very physically active person, and some people just have a lower heart rate to begin with. Not everybody's going to be is going to always have to take something, because my resting heart rate's in the 50s.
Right.
If I was put on a beta blocker, I might have would feel really poorly. So yeah, it sounds like they had you on the normal starting dose, and did the right thing and went down. Again, wasn't there, but it sounds like they did the right thing to kind of help figure that out for you.
These are all such great questions, everybody.
Yeah, they're great. I love them.
This was wonderful. This was a wonderful night. Again, if you're just joining us now, we are going to wrap up and say goodnight, but this video will be out there on Facebook and on our website, aortichope.org, so you can take a look at it anytime. And don't forget the secret part that I mentioned that's in here. So now you have to watch it if you want to play. If you got to play to win, you got to watch the video to see it. But thank you so much.
You're welcome. It was a pleasure.
We are looking to have a symposium in Maryland in the spring.
Awesome.
I'd love to have you
I'll
come
be
give
there.
a talk. That's wonderful.
I'll be there.
All right,
you guys
everybody.
are in great hands with this lady.
Thanks so much. I love doing live events. I get to get my hair done. All right. Have a great night, everybody. Thanks again for joining. Bye-bye.
Did you get your hair done today? Did you do it?
Bye.